Welcome to the Cold Steel Surgical Podcast with your hosts Amir Farouk and Chad Ball.
Dr. Bellal Joseph is a trauma surgeon and the chief of the Division of Trauma, Surgical Critical Care, Burns, and Acute Care Surgery at the University of Arizona in Tucson. While it was impossible to delve into the breadth and depth of his research interests, we did explore some of our favorites with Dr. Joseph, including his ongoing investigations into new technologies like REBOA, traumatic brain injuries, and frailty in surgery. What shines through in this conversation was Dr. Joseph's incredible authenticity, energy, and passion for injured and disadvantaged patients, as well as his vision for how physicians can embrace their own brand.
Before the start of the show, we were hearing a little bit about your amazing family background, but tell us a little bit about where you grew up and where you did your training.
Yeah, I grew up in Toledo, actually Maumee, Ohio. My dad is one of 10 and my mom is one of 12, and they were all immigrants from Lebanon. And I was one of 100 first cousins, and there's only like 4 of us that went to school. It's kind of crazy, but my mom was a big believer in pushing education because everyone just worked in the family businesses and restaurants. And so I actually didn't get into a U.S. medical school. I went to a foreign medical school because I was one of the first college grads. No one didn't know what any of that was. I'm not making any excuses, but it was like learning as we went. My dad's like, just stay home and do business with me. And my mom's like, go, go, go. And honestly, then I didn't match. I was a prelim at Henry Ford where I did my surgical residency. And that's a whole other story about the match and how I, got no interviews. And thankfully, I worked really hard and I was able to, stay on as a categorical. And then I only had 2 trauma fellowships that gave me opportunities back then, one at Shock Trauma and one at the University of Miami. And Dr. Scalea allowed me to come train with him at the University of Maryland, thanks to my chair who, made a phone call for me. I wasn't the hottest ticket on the market, I would say, but I trained at Shock Trauma. And then, I really wanted to go back to Detroit and be around my family. And you always think that you're going to find the job that you want. And then you realize really quickly, like, the job has to be open, it has to be right location if you want mentorship. And so Peter Reed was starting a trauma center here in Tucson, and I knew nothing west of the Mississippi and made my way out here. This has been my first job and my only job, but I took a chance coming out here, and it's been a great journey.
I want to actually, for 2 seconds, talk about your IMG story. And, unlike Chad, I don't have the pleasure of having met you in person, but I've been an admirer of yours for a long time on Twitter. And I noticed how supportive you are of medical students who don't match or don't get their categorical spot. And I can sense there's a real story behind that and a real, almost like a pain and a sympathy and an empathy for people who are going through that. Can you tell us a little bit about that story?
I mean, sometimes I wonder what drives me and why it's never enough. And I do think it's because I always call it success through failures. There were multiple failures in my career to get here. And I think it makes it taste sweeter, but also not everybody knows your story of like what it took to even get to prelim spot. And I think our legacy, and that's what my mother always taught me, was to, someone put their hand out for you at some point in your life. You better put your hand back out and help someone else. And of all the things that we get to do, and I'm sure Dr. Ball can attest to this, it's the people that you've been able to touch in many ways, whether you know them or not. And I think the only thing I say about that is I'm a big believer in people cross paths and fates for certain reasons, whatever it is. And the only thing they take away from that interaction or that moment, whether it be on X or on Twitter or in person at a conference or while you're training them, is really that interaction you have with them. And that's because that's the way I was raised by my parents more than anything. It's not about money. It's not how rich you are. It's not what your CV shows. It really is that moment that you have to kind of show who and what you stand for and what your roots are.
That beautiful way to frame life that doesn't surprise me coming from you. I've known you we've known each other for quite a number of years, but I've never asked you what sort of tickled you in terms of going down the injury, the critical care, the trauma route. Why did that speak to you in particular?
Sometimes I don't think I knew any better, and I was really poor growing up and I needed to finish quickly. I know it's going to sound crazy, but I also know that my family was a blue collar family. And, I have family that doesn't have health insurance, for example, and I go on and on. But like caring for that population for me was like everything. It was like giving back to the world I grew up in. I mean, I remember being a fourth year student on elective as an IMG driving past shock trauma, saying that I'm, someday, it's just like a little dream of mine. I'm going to come back through here. But the trauma was like, everyone's equal. I was like, I'm going to go a little religious here. I'm sorry, but it's like Ramadan, right? Like when you fast, no matter how rich, how poor, where you come from, everybody's fasting, everybody has the same rules. And I feel like trauma, when it comes to the care of humanity, there is no line, right? Whether you're rich, whether you're poor, whether you've got you come into the trauma bay as a human that needs help. And I think that's really what allowed me to go to that. And then honestly, it's the jack of all trades, right? Like it's the ability to do all of that and deal with human life at the highest level. There's no other profession that gives you that privilege and that honor.
I couldn't agree more. That's so well said. And I think I would echo a lot of those things in my life, whether it's locally or regionally or globally. It's just so relevant from, the individual in front of you to the public health kind of epi side of things. It's awesome. That's an interesting transition because you've done so much in your career so far, and you're well known. Your performance has been unbelievable. We all learn so much from you regularly. Like it's been just a pleasure to be around and to watch and to learn from you. But I'm curious, on the research side of things, where did that particular drive come from? Who influenced you? How did you get to the point where you contribute such interesting and novel stuff?
Little disclaimer, a little secret. I had one paper when I left fellowship. And, Vic Volanovich, who was a cancer surgeon, a foregut surgeon, was my residency mentor. And he helped me write that first paper. And it was more about just the joy of working as a team. But research for me, and I remember interviewing here and Peter looking at me like, you want to be an academic surgeon? What does that even mean to you? And I didn't even know how to answer him because he wanted an academic surgeon. And I'm like, I don't even know what to say to this guy who I've read every paper he's ever written. And honestly, I love clinical medicine. I love clinical care. Felt like we were trained really well at Henry Ford in Detroit and then even in Baltimore. Like it was very clinically focused. But I have the unfortunate disease of asking questions and asking why, or the fortunate, whatever you want to call it. And that honestly has been, it's just kind of like my career. Like when I was told you can't, many times you'll never match, you'll never be a surgeon, you'll never, and then you come to clinical care and you get the opportunity to do that. And people start telling you, well, why do we get repeat head CTs? Just because that's what we do. And so proving something that's never been proven to be true. And if you look at the work that we've done, people always think I'm all over the place. I'm really not. It really is a discussion on rounds. It really is a discussion in M&M between two attendings where, people, I'm sure, are having the same conversation all across the world. And that's what's driven it. I mean, I wish I could have done 2 years in the lab and got it in a PhD. But I'd be lying if I said that was ever part of the plan. The plan was just to care for people. But you can still care for people through research. And I think sometimes people forget that. It's not about what you publish, it's the ability to impact people's care.
Yeah, I think that's well stated, and for guys like you and I think, it's fair to say that we both try and ask narrow, relevant clinical questions. And you're right, again, in the field of injury and trauma, to go back to what you were saying, it applies globally, which is really neat. If you're writing a paper on a Klatskin technique, well, like honestly, on a public health point of view, who cares? But the stuff you do is just so relevant. It's amazing.
I've been dropping your name in your paper on the ultrasound of the pancreatic duct, as like, and everyone's like, oh, he's an HPB surgeon. And I'm like, listen here, I've known Dr. Ball for a long time because I was just at, university in Canada. But I tell people, I'm like, well, like the ability to take your knowledge at such a high level in whatever field and bring it back and translate it into real daytime practice is really what drives. And to your point, I agree with you. Like I read all of your stuff and I'm a fan likewise, and so like your ability to take something that may be adopted or brought back into what we do and make it better. There's nothing better than the ability to start that. So I hear you. I hear that message a lot when I'm out there. So
Well, one area that you've definitely not stopped asking questions about, and I can say this as someone who's followed you from afar, is REBOA. So for the people, like let's say the medical students or junior residents who don't know what REBOA is, can you just give us a little bit of a synopsis on what the REBOA technique is and why did you get interested in asking the questions about REBOA?
Evolution of care and making things better is part of that whole research clinical question, right? Like, how do we improve what we do? And REBOA is not new. It's been around for a long time. It's your ability to, basically control the flow past the aorta. And anyone who tells you, I'm a surgeon master, it's so easy just to grab the aorta with my finger, the supraciliac aortic clamp or whatever. And I've watched surgeons open chest to grab the aorta. I've watched surgeons try to, tear livers to tear, to get in the aorta. But like the ability to control inflow, which is a big principle in trauma, so you can fix whatever's broken, is a huge thing. So REBOA, started making I put the first REBOA in the state of Arizona, and at that time it was not called REBOA, but it was a 12 French balloon catheter. I had a lot of interest in, oh my God, like look at our ability. And every time I hear technology, and you look at a lot of the papers I've written, I like, let's see if it really works on the clinical. Like I'm gonna be the soldier who's gonna put this on the patient and see if this works. And that has been, so the REBOA would have minimized or would have supposedly by theory improved our ability to get aortic control without a secondary incision, and just kind of fix it. The balloon is not what's going to fix or save someone's life, right? It's going to temporize blood flow. And I was flabbergasted that we could, do this. Is kind of cool, and I was thinking about it. And so we did it. And really that's my interest came in when I had a partner who put a REBOA in someone, didn't inflate the balloon, and then took the balloon out after CAT scan, didn't need it. 18 hours later, no one was doing pulse checks. No one was doing anything. And the kid got an amputation. And that was hard for me to swallow. This can't be the only place that this is happening. And then, our first paper, our landmark paper in JAMA about REBOA really was just like, what does the data say and right now about all these REBOAs going in? That's all I said. I didn't, and I'm a big believer in just to kind of get a signal from the data. And it showed like more people dying or higher numbers of deaths with a lot of amputations, a lot of acute kidney injury, like those things that we wrote about 6 years ago, we're still, every time someone looks at the data, it's still the same numbers. It's kind of funny 6 years later. And so, and my interest, I would never wanted to be the villain. I was just trying to say what the data says, but this is a good lesson for the students and the residents. When everyone seems to be looking one way and fixated on something, the ability to ask the question and just kind of look the other way to kind of get everybody's attention is a great way to start your question of whatever you're trying to, your science. And I think that was the thing. And I'll tell you the villainness of the REBOA, I think, came because people just read me the wrong way when and I had been working with the companies. I was begging them. I was like, I took the course. I mean, this wasn't like me just working on the outside. I took the course. And then you walk in there like, okay, 1 unit of blood put up there. And I'm like, what are we talking about here? Like, that's not right. That's not what we do. How many patients flip back from this? And then, the ability to put that in. And then finally, the last piece is another lesson learned. Like you put that balloon up and, vascular surgeons taught us this 50 years ago. Ischemia reperfusion is a real thing. Like it's, and so time to hemorrhage control and all these concepts were happening. And, resuscitate. I mean, that's the other thing. People, sometimes talk about things in subject, but as REBOA is happening, we're moving to 1 to 1 to 1. We're moving to whole blood. We're moving to TXA. And we're moving to TEG. And so all this is happening at once, but everybody wants to just say, this one thing. But it was part of a bigger discussion. And I could talk for a long time about this, but it really bothered me that people started putting balloon up equals save life rather than balloon up gets me to where I need to go. So I don't know.
There's a reason why I asked you about this because I found this whole, we on the podcast, Chad and I have spent a lot of time kind of talking about REBOA because I think it's emblematic of a lot of interesting things in surgery. I mean, one of the interesting things that we know about surgery is like it takes a long time for innovations to diffuse. But on the flip side, sometimes it seems like these innovations take off and it's hard to put the genie back in the bottle, even when people are saying like, oh, this is not what we thought it was. What do you think drives innovation in those two separate directions?
I think one regulation, right? If this was a drug, it would have been pulled from the market the first 6 months it was up. But it's not, it's a device. And so devices have the ability to work differently. I think the military use of REBOA is very different than civilian use. I think we have to be very clear when we do those things, we talk about those things. I would say if we didn't ask those questions, also this came to my head when you were talking, like we have advanced REBOA more than most people who are proponents of REBOA. We have made it better for patients. And I think that, unfortunately, industry partner relationships, I know we're going to talk about that, it's important to understand what you're talking about. And then people want to believe. I mean, Dr. Ball, I'm sure Chad, you've seen this numerous times. Like, this hot thing comes out. We had, I mean, we're not talking about today, but a few years there was this non-invasive hemoglobin monitor that you could stick on people's finger, and it was supposed to give you the hemoglobin. I'm like, perfect. We need to stop Q6-hour labs for liver and spleen injuries. We'll just put this hemoglobin. So we went and we tested it, and it wasn't ready for prime time. And so this, theory and then actual practicing where we're improving patient care are two different things. And sometimes people just, get caught on a whim, and it's amazing. Like you said, it takes multiple papers to change practice. It really just takes the ability to make people believe. And then some things it does take 100 papers, and some things it takes 2. And you're like, how, damage control resuscitation is another. If you look at the original index paper, it was 19 patients that changed damage control resuscitation and our approach to it. Like, it's just crazy to think that when you get into the details of the reality of science. And so we try to be good stewards of science. And then anybody who brings anything in front of us, not just say, we're not here just to practice trauma. We want to write trauma, and we want to study it too. So like, I encourage my fellows and my faculty, like, always ask why, and always ask, is the data really clear? And if not, you prove the data, you help the data.
The last thing I do want to touch a little bit on that, because I found this fascinating, is, you published this paper on conflicts of interest around the topic of REBOA. For folks who don't know, the company actually essentially tried to prevent you from speaking on it at a major conference. What was that experience like, and what did you learn from that whole experience?
Maybe I'll come back on here and talk about the book. No, I'm just joking. So I will tell you, had I not been as, look, you can take an academic hit for some of these things. You got to be careful. Like, it's a strong mafia out there. I don't know if that's the right word, but like, academic medicine and the science and learning, it's not as straight as people think it is. And I don't mean that in a bad way. I do think that, and you should never just do things for fun or but what I learned really was, I didn't realize how powerful, when you disrupt what people want to believe, it becomes a big thing. And the company and the disclosures, I mean, we were watching people write huge papers about a device and reviews and not disclose. And we knew for a fact that they, helped develop and not disclosing any of it. And I didn't do it from an intention. I didn't write a single human's name in my paper. It wasn't about that. And this idea of using the Sunshine Act and disclosing, and it's funny, like, I feel like trauma, if you go to vascular or orthopedics or radiology, disclosure is a normal part of what you do. You just disclose, and whatever you write then after that, it's up to the people to read. That interaction, I learned more in my career, but I took a hit from that. I really did, an academic hit, and it's okay. Like, I will go to bed at night knowing that I didn't do this out of malice or out of hurting someone's company, or I did it out of the what was right for the patient.
Yeah, I'd second that. What you did was brave and honest, and what we need more of. If we switch gears a little bit, you've written a fair bit and talked a lot about traumatic brain injuries. For those listeners who may not know, what are the brain injury guidelines? Maybe you could start with, and then give us your view, your sort of frame of the interaction between, trauma surgeons like us, critical care intensivists like us, and the neurosurgery side of it in regard to consultations and care.
Yeah. So the brain injury guidelines help, not all brain bleeds are the same. They're like snowflakes. I always say that. And we get into this, if you said abdominal pain, you could give me 9 differentials. And for a long time, we just said bleed or no bleed. And Arizona's, Tucson is a very rural area early on when I first started here. There's not a lot of resources, not a lot of neurosurgeons. And I just want to start by saying, if it wasn't for our neurosurgical colleagues who had the vision also to look at the problem and say, how do we fix this together? Right around the same time, the emergence of acute care surgery and what we really did. And you look at all brain injury, 90% of it's non-operative. And we are intensivists, as Chad mentioned, that are taking care of these patients. And I was doing work with hypertonic and other things and remote ischemic conditioning and brain injury. So I had a very, I was super excited about, traumatic brain injury and how to move the needle and so rounding every day again on the bedside. And we'd admit these patients to the ICU, Q1 hour neurochecks, repeat head CT. Sometimes it was 6 hours, sometimes it was 12, sometimes it was 3 or 4. And then finally, the next morning, a second year, first year neurosurgery resident would come to me and be like, hey, we're signing off. And, which was appropriate, but like, who was doing the neurochecks and who was why did I call neurosurgery for these? And that was really how it came about. It was a bedside. We were like, our ICUs were full of patients and so the brain injury guidelines really said, well, we're going to define different types of bleeds, and others were working on this at different levels. And you define the bleeds based on the type of bleed, the location of the bleed, whether they were on anticoagulants, and the neurological exam. We went away from GCS and other things. We were like, these are things that actually impacted. And then based on what you found on the bleed and the presentation, the clinical presentation, we put them into categories, big 1, big 2, big 3, meaning, we could discharge them from the ED all the way to they needed to be admitted and get our neurosurgical colleagues. And it really came from the repeat head CTs. I wrote 2 papers on repeat head CTs. One was a prospective repeat head CT in patients greater than GCS of 8 who had no anticoagulation and showed without a change in neuroexam, you never intervened or did anything about a change in repeat head CT. And then the second paper I wrote on that subject, which is still one of my favorites, it doesn't get a lot of noise, is greater than 2 repeat. I mean, we were getting 20-year-olds with 2, 3, 4 repeat head CTs. And I was like, what are we doing? And so that started with the repeat head CT, and then we went into that. And so we established the guidelines. And to your point, as you mentioned, Amir, like that was 2013, 2012. And it wasn't until 23 or 22 that we finally got the validation study through the MIT. And that was 10 years of trying to write about this subject in different ways, about the anticoagulants, about the repeat scanning in different parts. And then we were able to bring it together. But it took about 10 years to get us to a point now where I can tell you there's a lot of states that have adopted big. Another area that we worked early on was with Alaska. They were flying patients to Seattle, and I went up to Alaska and gave a talk. And then we started talking about this, and there was a huge need. And a lot of these transfers we get to Tucson from our rural areas, we didn't do anything. The CT scan that we did at our own institution would be normal. And it was like a Ditzel bleed at an outside hospital. And so all that together helped us develop the brain injury guidelines retrospect. And we were super conservative with defining the brain injury guidelines initially, and our neurosurgeons were there. I mean, I remember the first paper had 4,000 retrospective charts we looked at. There was one patient with a 5 millimeter bleed that had progression. And because of that, I was like, we went back to 4. That's where I got the 4 millimeters from. But we had a 0 line there. We couldn't, when we first started this, if we made one mistake or had one patient outcome poor, the whole thing would have been gone. And so I was and it's fun to watch people now push it a little bit and advance it. And I think that's another learning point for science. Like, you don't have to go to, get to the finish line in the first paper. You should just, you open the door and you start establishing the pathway to get there, and then let others come by. I get excited when others start talking about it and show it. It's not, it's fun to watch.
And I think people have recognized the work that you've done. I know you recently got, a $3 million grant from the U.S. Department of Defense to study this. So congratulations. And it's just amazing. It really is. It's quite hard to talk to you about your body of research, because there's so many things that we could ask you about. One thing that, piques my colorectal brain a little bit as well too is, all the work that you've done on frailty in surgery. Can you talk a little bit about the index that you developed for frailty? And then the part that I always think about, especially in the acute care sort of trauma side of things, is, you can define what frailty is in these patients, but how does that change what you do and how you manage these patients?
I trained early in the 2000s when age was the only, man, I remember they'd be like, oh, there's 75, they can't have a Whipple. Or it's got a bad head injury and there's, 70 or 80, we're going to turn everything off. And that was really hard for me as a student trainee, resident trainee. Then when I got to Tucson, there's a lot of older adult population who come here. And I got tired of hearing people do this bedside, like, oh, they're old, oh, they're, and I was like, I can't do that. Like, we need to think about this. And I started looking, and Mindy Fain, Dr. Mindy Fain, I got to give her credit. She's a geriatrician here. I bumped into her early on. She invited me to become a Reynolds Scholar in older adult care because geriatricians were they knew there wasn't enough of them. We're trying to disseminate older adult care into other professions. And so through that, frailty came into place. I'm like, frailty, what is this? Like, I started reading about it. Ken Rogward, Linda Freed, and their frailties. And the first time I presented frailty at our research meeting, Peter Reed got up and walked out. He looked at me, he goes, and he gave me a thumbs up and a thumbs down. He's like, I don't need your frailty score. He literally, and I was like, oh my God, there it goes. Like, there goes my career, just to show you where this goes. And that another motivation to push this. But surgeons do not want to sit and do a 50-point frailty or have the ability. And that's why we created the 15-point frailty index. And ground level falls and trauma are probably the single most reason why trauma centers in this country proliferated in the last 15 years, because there's so many ground level falls, but it's not just the ground level fall. And so we were able to validate the trauma specific frailty index. And this year, the COT and their best practice guidelines recommended it as, for every older adult should have a frailty index. Now, back to your question about how we implement. I mean, the first 5 years of this research was just to say, if you were frail versus non-frail, I mean, the numbers are the death rate, the recurrent trauma, the recurrent fall. It was just staggering. The data was just staggering. And people always forget, if someone wants a secret, to go learn about the pre-frail, because it'll get back to what you're asking me. I mean, like, what should we do with the pre-frail before they get in? Because frailty is a spectrum. You're not frail forever. It's like, I always think of it like a bad pneumonia that you can treat if you do it right. And so, even in acute care surgery, hospital systems, hospital administrators now will say, oh, Joseph was on, look at this death he had. He didn't rescue this patient. And they're always blaming the physician or the health system. No one ever had a patient level factor documented that we could say, look, they're frail on presentation. This plays into that equation as you make my grade card as a trauma surgeon. That was one. Two, I think that if you were a 20-year-old with 3 rib fractures and you were a 60-year-old rancher with 3 rib fractures and you were a 65-year-old frail person with 3 rib fractures, all those patients got the same pathways, the same discharge processes, and what we learned, and I said rancher because all our ranchers go home after, 24 hours. They're all amazing. But like, what I learned was, like, now if you're frail, because we can't do this for everyone, we set a different discharge pathway for these patients. So even if you are frail and then you have injury, how we treat you in the hospital, medications we use, our ability to rescue you, our attention to you, the nurse training, the physical therapy training, because we can't do that for everyone. I wish we could, but we're not there yet. And then our discharge planning and our readmission planning, we have a frailty clinic with our geriatricians that they follow up on. I mean, I could go on and on. So this is an intervention point that allows us to document it objectively. I'm not guessing, oh, they look frail or they look old. I think that was one. The other thing I'll tell you where it really played big, I know this is more trauma, but like in the emergency general surgery, like for a long time for people like who had, gallstone, cholidocos and, stones in their ducts, and they're like, oh, sphincterotomy, they're old, let them go. And then we're like, well, and it sounded great that we would discharge these frail patients because we didn't want to operate and take out their gallbladders and send them home. And what the frailty actually did, and even for appendicitis, was we learned that this non-operative, minimal approach may not be the best thing on a long-term 3-month, 6-month outcome. Those patients come back with worse outcomes, with more death, with more complications, and maybe they are now in front of you. You can actually, treat them right there and give them definitive surgical care while they're in the hospital under your care. And that's a different way to approach this. So it's kind of opened our eyes to not only think about the patient in the hospital right now, but their discharge, their 3-month, 6-month follow-up for both trauma and emergency surgery.
That makes so much sense. And when you frame it like that, when you have it really is almost like a turning point for you, it sounds like, at your institution, where you can really say, well, this person is frail. Let's get to work on this person, almost like, not to belabor or use double puns, but like with a surgical sort of approach, you can really just go and target those patients who are frail.
In the next 5 years, like we've done is said frail is bad, and these are the things: quality of life. The next 5 years is out, and that's why prehabilitation centers, and you're right. You said colorectal. You look at cancer. Frailty has disseminated across the board as a subject matter of identifying and going. And I think even for now, frailty pathways. I mean, the things that are happening, because of just defining this disease process in an objective manner so everyone could speak the same language across multiple centers has now allowed us, the ability to now think about how to treat it, which is the next 5 years. If someone again wants a fun 5 years, wants a career, there's a career for you. And one last thing I just want to mention about the older adults, like even like resuscitation and trauma, we've come up with new terms like inflammaging, coagulating, where it's the eight, we're seeing things like in their tags and their profiles based on their age and their frailty, the way their platelets function, the way their they respond to blood. I mean, it's exciting. Like it really is exciting. I would tell you, I used to think a 20-year-old shot in the belly is the most complex trauma case, or a blunt trauma. You give me a 70-year-old frail patient who's been injured, whether it be blunt or penetrating, that is a difficult patient to resuscitate and save. And that's kind of now our understanding of those things, and why and when and how is very different. It's not just, they're old, let them die. That theory is gone.
Yeah, I couldn't agree with you more. Dr. Joseph, like I said at the top of the show, one of the things that I have really admired about you is your ability to use social media to affect people. And I mean that really sincerely. I think, it's too easy in this day and age to kind of use social media as just another platform for your own personal advancement. It's just another way that you can be the loudest barking dog at the podium, so to speak. But you really haven't used it like that. You've used it in a way to really inspire. And I genuinely I don't even know if people who follow you necessarily pick up on all your tweets. Like I pulled a bunch of some of my favorites. You genuinely say things that I really enjoy hearing. Like you wrote, "When God gives us more than we deserve, what should we do? Give back, consider it as if he's trusting you with resources to spread carefully to those in need. Always give." Another one you wrote, "If you want to shine in front of everybody, you have to work in front of nobody." Oh, that one is a beauty. No, here's another. "If it costs you your peace, it's too expensive." I want to ask you, how do you view social media in your practice? And it clearly, at least to an outsider, it seems like something that's important to you. Why is it important to you? And what do you think the value of it is for you as a researcher, as a surgeon?
There's not a lot of free things in this world, and social media is free. That's number one. And I don't say that lightly. Physicians are the worst when it comes to branding ourselves and branding our purpose and our cause, right? Like we're a brand. And sometimes we let hospitals and health systems and universities minimize our brand as individuals. Like we are the brand. And when we get out of medicine and we get into the executive suites and leadership, I was an early adopter of social media. And I realized that it meant something when I gave my first journal club on social media where someone was reading it. It's actually University of Michigan, and they asked me to come on Twitter. I was like, oh my God, this is like, and then my first collaboration across the country or across the world where I was dealing with, talking to people in Australia, I was like, the power of this is just, unfortunately it gets overwhelmed by talking about politics and all these other things. And I think you gotta be smart about it. I think it allows you to express yourself. And I think my biggest, magic or tool is like, just be real. Like people if you're thinking something, there's 1,000 other people thinking like you and relating to you. And so I think of social media as a brand. I've been able to put Tucson and our fellowship and our trainees on a map. I learned so much from social media. I read all my journals through social media, the access. And then the last piece that people forget about, like maybe you and I and Chad are like, call each other, text each other, like that's cool. Like we have to communicate with the generations behind us. This is their language. And if you're not, adapting and changing yourself to the language of the younger generations, how are you ever going to connect? And so those have been the things. I think it's a brand. I think we all need to learn about branding ourselves. It's not a sale. I'm not selling myself, but I represent something. And what is that? And my science and, I think there's a lot of people that have done so much work showing that when you put your science on social media or others put it, you get 7 times more engagement. You get more people to read the work. You get more people to learn about it. And I mean, how, like, I just have a hard time for someone trying to explain to me why they're not on and why they're not using it, especially world leaders in surgery who, if you're a resident, every program director, every fellowship director, every chairman is on social media. Like, that's your connectivity. So it's hard. Don't get me wrong, but I am very careful. And, I've had some messages go out that probably shouldn't. And we have all personal and emotional things with the current world climate at different levels. And it's hard to hold yourself. But I think when you put it into the box that this is part of my brand as a surgeon, and I keep it in that box. But I also think you can't just be, nobody wants the robot. I put my kids up there. I'll post food, because I think people connect. Like, at the end of the day, you're not, when I give talks and stuff, no one looks at your slides. No, people listen to your voice and they feel you. And I'm a big believer in that connection of the soul. So.
Oh, I love that. Well, thank you so much for spending time with us today. We know how busy you are, and the word busy probably doesn't cover it, but we really, really appreciate you, and our listeners will be really, really pleased with your talk today. One of the things we always end the podcast with, as is to ask, if you were to go back in time and sort of meet or look at yourself as maybe a chief resident or starting out, as faculty early on, what would your advice to yourself be these days?
Surgery is hard. And, we always thought we were robots. I trained in that phase of just be tough. It's okay to be emotional. It's okay to connect. It's okay to feel as you're getting trained. Your families are important. Many people talk about, your kids and your mom and dad may or may not ever look at your CV. I dedicated a lot. I gave everything to surgery, and because that's what I was told to do. And I think that, we're in a better place today than we ever were. And if I could, going back, what would I tell myself? I said, one, it's okay to take care of yourself. So long, there's no destination in this run. It's just, it's the next mission, as I say it. And it's okay to stop and think and to feel and to cry and to be angry and to be upset and also to be happy and enjoy and marinate on your moments of success and not feel like you're just running, lose the imposter syndrome earlier, because I don't care if I was a prelim and I didn't match, and I go on and on. And even on this side, I'm still the same Bellal I was as a chief resident. And I think it's just what you allow others to, I'm very, I love to connect. So when people don't connect, I feel that. But I think I would tell myself, like, this is about you and what you're giving back. Stop, don't be so stuck on what others say about you and think about you. So that's probably what I say. Number 3, the last thing I would just say is, the patients are everything. And I don't have to make it all like I would have changed things. I'm so thankful. And I would have whispered to myself, you're going to do great things, because not what I did or what my CV, but the number of mentees and fellows and international fellows and patients we've impacted with what we've done is just a beautiful thing. And so if you can do anything to keep patients, because we all chose this for that reason. And I think no matter what angle you go on, it all comes back down to that ability to stand at a patient's bedside and have the privilege to take care of them.
Oh, I love it, dude. Oh,
That was awesome. The only thing I wish we could somehow have worked into our interview with you is an amazing clip of you doing Dancing with the Stars.
No.
I found that on YouTube. That was awesome. Thank you so much for joining us.
you're a prince. I love you. Be well.
Thanks, brother. Appreciate you guys. I'll see you guys soon. We'll get you guys down to Tucson at some point. That's my goal.
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you have comments or questions, please email us at podcast.cjs@gmail.com. Thanks for listening.